Welcome to the first session in the Data for Health, Data for COVID-19 series hosted by Bloomberg Philanthropies. My name is Carlos Roig and I'll be moderating these sessions. This morning, we're joined by more than 240 participants in more than 50 countries. This session is being brought to you by Bloomberg Philanthropies, an organization founded by Mike Bloomberg that uses data to ensure better, longer lives for the greatest number of people. As you know, the goal of the Data for Health initiative is to partner with countries to improve their public health data. The COVID-19 pandemic has reached nearly every country in the world, and during this crisis, high-quality data is more important than ever. This series aims to provide technical assistance to support your ongoing COVID-19 work. Before I hand this over to Philip Settle of Vital Strategies, I wanted to go over a few pieces of information to help you navigate the platform. Most of you are viewing this webinar in attendee mode, and you will notice a Q&A button at the bottom of your screen if you're using a computer, and at the top of the screen if you're using a phone. Please use this feature at any time to type questions you have about the presentation or anything related to the series. And please include your city and country when you submit your question. Vital Strategies, along with other international Data for Health partners, will answer as many of these questions as possible at the end. Up next is Philip Settle at Vital Strategies, who will lead the presentation on rapid mortality surveillance. Philip Settle is a medical anthropologist and social demographer with 30 years experience in global health, working mainly on topics related to civil registration and vital statistics. He has published numerous books and articles on topics ranging from the social demography of AIDS to civil registration and verbal autopsy. Previously, Dr. Settle has held leadership positions at Measure Evaluation and the Bill and Melinda Gates Foundation. Currently, he is Vice President and Director of the Civil Registration and Vital Statistics Program of Bloomberg Philanthropies Data for Health Initiative at Vital Strategies. Philip will also be joined by his colleagues at Vital Strategies, Dr. Martin Bracci and Dr. Adam Karpati. Over to you, Philip.
Thank you, Carlos, and thank you everyone for joining on our webinar on rapid mortality surveillance for epidemic awareness. Next slide, please. An evidence-based response to this epidemic is going to be based on knowing its scope, scale, and impact. Know your epidemic, know your response, as the saying goes. And yet, as the New York Times pointed out recently, no country is really sure how many people it has lost to the COVID pandemic. Next slide, please. This uncertainty of numbers, this confusion and conflict even over what should and shouldn't be included in various counts of cases and deaths has played out in the press. It's really a very open secret that there are ambiguities and confusion in this area of understanding the epidemic. Next slide, please. And it's worth taking a moment just to remind ourselves where this ambiguity comes from. I think we are all aware of the challenges around measuring cases with regard to the availability of testing and its use primarily in the clinical context. The way in which testing is limited, the way in which it's implemented, makes it challenging to use confirmed cases, as we know, as a measure of epidemic impact and burden. And we have seen countries begin now to use suspected cases in addition to confirmed cases. So that's an attempt to get a handle on the morbidity component of the epidemic. In terms of mortality, well, COVID-19 specific mortality can actually be a challenge, particularly in the countries with which we are concerned in the Data for Health initiative. Please, next slide. There are a couple of points I'd like to make. First of all, that measuring COVID-19 deaths is not yet or may never be entirely straightforward. And secondly, that in a few different ways, it may only be telling part of the story to do so, to focus on COVID mortality alone. First of all, it's not straightforward necessarily because in the midst of this pandemic, both certifiers and coders are going to need to absorb new guidance from WHO and from the ICD on the proper use of two emergency codes that have been issued by the organization and by the ICD for COVID mortality. There's guidance that needs to be applied. There are coding rules that need to be applied, and this needs to permeate in the health system to begin to see COVID appear on death certificates. So that needs to happen. It may only be telling part of the story in a few different ways to focus on COVID mortality. First of all, there's a question more broadly that many of our countries, many of data for health countries and low and middle income countries are not yet using ICD, particularly in sub-Saharan Africa. So there are immediately questions about the exact quantities that are being reported about COVID mortality from countries that aren't using ICD. It may only be telling part of the story because many deaths may be taking place at home. In countries with limited and strained health systems, that proportion of deaths may even increase. And it may only be telling part of the story because we know that there is an indirect mortality burden associated with epidemics. We had seen that in the case of Ebola in West Africa in the last outbreak. And we can identify excess deaths that are associated with COVID-19 mortality, but not necessarily due directly to it. And that's a big concern as well. And lastly, there are environmental conditions that are starting to affect the picture. We know that in some countries where insurance companies are indemnified from paying claims in the context of a pandemic, there's a huge incentive, and we do have reports of this, a huge incentive for falsifying cause of death on a death certificate to say anything but COVID if an insurance company doesn't have to pay a claim if the COVID appears on a death certificate. So all of this is to say that this may add up to a murky and incomplete picture. So if we have these measurement challenges around specifying COVID-specific mortality, what if we were, as we are beginning to consider doing, looking at total mortality? Next slide, please. In the CRVS system, it's a place where we would expect to find such data. And yet, it may be a challenge to move into that space expecting rapid mortality surveillance in the context of the epidemic unless systems are digitized. First of all, we know that civil registration can suffer in an epidemic, and there are early signs of this already. And this is in a context in some countries where mortality registration is already low. So the impact of registration, the impact on registration under conditions of lockdown, stay-at-home orders, or other public health measures may be missed events, and it's unsure whether, particularly in the case of deaths, those would ever be recovered. Lastly, the point I made at the beginning, CRVS systems are not necessarily designed for the speed required in the context that we are facing right now. However, where it is digitized, it can be leveraged. There's a great example from South Africa, for example, leveraging their population register. Next slide, please. So let's take a second to see where we are. There's confusion over measurement of the epidemic burden and impact. There's challenges and issues related to measuring COVID-specific mortality. And there is a place to get mortality data that may not be optimal under the circumstances. So this brings us to the notion of rapid surveillance of total mortality. Doing so will provide an awareness of the trajectory and distribution of the health impacts of the epidemic with speed and simplicity, because it's designed to detect all deaths just by age, sex, and location, and leveraging existing systems wherever possible. It helps get us out of this measurement ambiguity question and out of the challenges that might relate to delays in attempting to assign cause of death in a very reliable and consistent manner in the context of the epidemic. It's sensitive to the contribution of secondary or indirect mortality burdens associated with COVID-19. And I know from the registration information that many of you sent in that there's a lot of interest in cause of death. And there is a place for cause of death investigation, well, which will be touched on later. But we want to stress that it should not come at the expense of the frequent, timely, complete reporting of total mortality that we are recommending in this model of rapid surveillance. Before moving on, I do want to call attention to the fact that there are some key assumptions that underpin such a system, ranging from full government buy-in to keeping surveillance workers healthy. These are important to bear in mind and need to be sifted out, tested, pressure tested in any country context in which the system is established. Next slide, please. Sorry, next slide. Yeah, thanks. So very briefly, in the remainder of the webinar, we're going to show how these issues play out in one location, explain technical aspects of the system, show how rapid mortality surveillance is already beginning to leverage existing systems in some countries in order to produce these data and share them. And then we're going to wrap up with some few additional technical points in our next steps. Next slide, please. I want to remind everyone to use the Q&A button, again, at the top of your screen, I think on the phone, bottom of your screen on a computer, and invite you to reflect on whether this model of rapid mortality surveillance that you will be presented with today is something that resonates. Can you imagine it as a feasible priority in your country? What systems could be leveraged in order to establish this kind of surveillance? Or does the model strike the right balance between feasibility, technical rigor, and speed? Where are there gaps? Where is there ambiguity? Feel free to challenge us. So next slide, please. I'd like now to ask Adam Karpati, who is our Director of Public Health Programs at Vital Strategies, to talk about how some of these measurement issues played out in the New York City context. Over to you, Adam.
Thanks very much, Philip. Welcome, everyone. I'm going to talk about data from New York City, from the New York City Health Department, and really publicly available data that they have been publishing since the outbreak began, and really just to illustrate some of the principles that we're talking about today about the value of rapid surveillance for mortality, in particular, the value of considering all-cause mortality as a key indicator, and giving a more complete picture of the outbreak. And really, I think this example illustrates how a nimble health authority, a nimble CRVS system can adjust and can provide this critical information. So this graph on the screen shows what was initially being reported from New York City. New York City has a population of about 8 million people. Over the course at the end of March into the April. And this is all, this is deaths specifically from COVID-19. So these are confirmed cases of COVID-19. And you see this just extremely dramatic increase during this time. New York City has been very hard hit. Next slide. Now here, what was in blue before is now in orange, just for because that's how they published it. But about a week and a half ago, the health department started publishing results from death certificates that had not been confirmed with laboratory confirmation of COVID-19, but that on the death certificate, the certifying physician had indicated that it was a likely COVID-19 related death. And you see here now on the left, the two curves then considerably increased the number of deaths attributable to the disease. And then the numbers there on the right, you see the confirmed and the probable now, showing this much larger picture of mortality. And the totals there at the bottom, you see that including probable deaths increased the total by about a third. They represent about a third of the total. And again, very dramatic. And you see here, as Philip was talking about, the core demographic breakdowns in this rapid reporting of age, sex, and location. In this case, these are the boroughs of the city of New York. Next slide, please. Now, in addition to these explicitly COVID-related deaths that together number over 14,000, the department published there at the bottom of this page, and this is a one-page report that the health department publishes every day. The bottom of the page, and I've blown it out here on the side, is additional mortality not known to be confirmed or probable COVID. So this is all-cause mortality in addition to the deaths that had previously been, that I was referring to earlier, and that's 10,000 additional deaths. Next slide. So to sum up, those 10,000 deaths not known to be confirmed or probable COVID-19, meaning no mention on the death certificate, and no lab confirmation. Next. That's over 40 days, just 40 days. Next. New York City, in New York City every year, there's about 55,000 deaths. That on average is about 147 per day. And there is some seasonal variability, but actually this time of year is pretty much we're pretty much in the average. So just taking a very crude estimation, that's about an expected number of about 58, 80 deaths over 40 days in a typical year in New York City. Next. So that means, that implies that there are in excess of 4,000 deaths where COVID-19 was not either lab confirmed or listed on the death certificate. Next. As I said before, that the original, those deaths that were reported on that report were the COVID-related deaths explicitly, and that was over 14,000. So then finally, what the data shows next is that in a little over 1 month in our city, the city that Vital Strategies is based in actually, we've had 18,000 excess deaths. And it's just a staggering number. And that, those 4,000 excess deaths that I mentioned above, some of them are going to be COVID related. Some of them will be not COVID related as a result of strains on the healthcare system, non-communicable diseases, et cetera. That will come later, that understanding of the detail. But here now we know in a much more complete way what the picture is in New York City. And just to say those 18,000 excess deaths, if you look up on this slide, I mentioned there are 55,000 deaths a year in the city of New York. So that's a third of the total annual deaths in excess in just 1 month. So really just illustrating how devastating this epidemic has been and the value of all-cause mortality to tell that story. So I'll end there and turn it over now to Martin Bracci, my colleague at Vital Strategies, to talk about the attributes of a system of rapid mortality surveillance. Thank you.
Thank you very much, Adam, and welcome everybody also from my side to this webinar. And as Adam just said, I think that this New York City example very well illustrates the importance of knowing all-cause mortality in the course of the COVID-19 pandemic. Next slide, please. What I would like to do over the course of the next few slides is discuss with you or explain to you the rapid mortality surveillance system that we are proposing and that we are developing together with our partners and WHO and others to come up with a technical package of a rapid mortality surveillance system that can rapidly be implemented to understand total mortality during the course of the COVID-19 pandemic. The proposed system has two possible sources of mortality information. That's facility-based reporting, so reporting on all-cause mortality from health facilities, and community-based reporting. From both of these sources of information can come from sentinel sites, so selected health facilities or selected communities, or it can be universal reporting if that is possible. As indicated before, and also because all of this reporting should happen rapidly, without additional overburdening of the staff at the facilities or reporters in the community. We are proposing very minimal data collection, basically age, sex, and location. We'll talk a little bit more in detail later on about this, but very minimal reporting about each death that gets detected. And along the same lines, it is also possible, both from the facility reporting and the community reporting, to consider reporting on cause of death. However, this needs to be evaluated critically and then determined based on local settings. The reporting from the two sources should come together at the central level, where the data gets compiled, there can be quality assurance done, and the data gets analyzed so that it can be sent to policymakers then for decision making. Next slide, please. Let's look at a few key issues around operationalizing such a rapid mortality surveillance system. The first point here is around sentinel site selection. The sentinel sites should be selected to be representative and to really cover all cause mortality in the area that is being assessed. Additional sentinel sites can be added to focus on vulnerable populations as needed. As mentioned above, we are recommending minimal data collection for each death. Basically, the 5 data elements mentioned here: date of death, age of death, sex, location of usual residence, and the place of death, that is in or outside of a health facility. To be able to compute excess mortality, there is a need to assess the baseline level of mortality, as also illustrated in the New York example. This baseline level of mortality can come from historical data. This may not always be available, especially if the CRVS system is not digitized. Or it can come from estimates. And we have some methodology that we're proposing to do that estimate, and we'll also be discussing that a bit more detail later on. In terms of reporting on the manner of death or cause of death, we acknowledge that that is very important, and it may be feasible in some settings, but it really needs to be assessed on a case-by-case basis. Next slide, please. In terms of the outputs that such a system will generate based on the data collected mentioned on the previous slide, the indicators that can be computed are the number of deaths by age, sex, and location, and then taking into account the population of the area covered, we can also compute death rates by age, sex, and location. With this information, percent deviation from historic or estimated averages can be calculated and then disaggregated by sex, age groups, and we have some age categories that we're recommending here. Location of usual residence, this may be relevant when looking at maps or when displaying maps. And then place of death, again, inside or outside health facility. In addition to this measure of percent deviation from historic or estimated averages, we can also compute just the sheer number of excess death, as was illustrated by the example in New York. And we can also look at the deviation from the range of what is statistically expected, and we'll see that on the next slide. Further, we can determine the Z-score, which is the number of standard deviations that the observed number of death is above and beyond what the average of what is estimated or from historical data. Next slide, please. So these 3 graphs will illustrate further the importance and value of rapid mortality surveillance in the course of the COVID-19 pandemic. The left slide is from a system called EuroMOMO, which is the European Mortality Surveillance System. This map shows the number of, with the color scale, shows the number of standard deviations, the Z-score, that the observed number of death is above what is expected. As I'm sure you're all aware from the media, in Europe it has been mainly Italy and Spain that have been very hard hit, and therefore they are colored here with the darker blue. This figure does not have any disaggregation, just pure excess mortality, all-cause mortality. The figure in the center is from the Swiss Federal Statistics Authority, and this has age disaggregation. So which are shown with the two green bands. The upper green band is what is statistically expected, the number of deaths per week that are statistically expected for people age 65 and above. And the lower green band is for the expected number of deaths for people aged below 65. And as you can see, this is for weekly reporting. As you can see, for the first few weeks of 2020, the observed number of deaths, which is shown by the blue line, stays well within the green band. But then, as you can also see, for the last 3 weeks reporting periods that are shown here, especially for individuals above the age of 65, the observed number of deaths goes far above what is expected in the green band. And then very similar on the third graph on the right from Statistics South Africa, this shows the expected number of weekly deaths, the forecasted number of weekly deaths, as they call it, in the orange line, with then the dotted orange line being the upper and lower band of what is expected. And the black line shows the observed number of weekly deaths for the first few weeks of 2020. And as we can see from this graph from South Africa, the observed number of deaths is within what is statistically expected. Next slide, please. Okay, having discussed a bit more the details of the rapid mortality surveillance system that we are proposing or that we are discussing here today, I would like to talk a little bit about some of the country implementations of this type of a system that we have started to support as part of our activities. Next slide, please. Thank you. We have 7 projects in 6 countries that we are currently supporting. These projects are active or proposed. These projects are in existing or previous Bloomberg Philanthropies Data for Health Initiative countries. We have been discussing with country stakeholders in these countries, building on the very close relationship that we have had with those country stakeholders in the Bloomberg Philanthropies Data for Health Initiative countries. We have been able to support these countries by rapidly pivoting our technical assistance to the needs of these countries, to meet the needs of these countries and support their response to the COVID-19 pandemic, particularly to allow for a detailed understanding of what is happening in terms of all-cause mortality in the course of the COVID-19 pandemic. I would like to highlight 2 projects from Latin America and 2 projects in Africa. For Latin America, first in Colombia, where we are supporting rapid mortality surveillance at the facility level as well as at the community level. Just to tell you a little bit more about these projects, at the facility level, we are supporting government to enable medical record staff to report total mortality from facilities and then to investigate suspected cases of COVID-19 to make sure that all deaths get reported and that there's a clear understanding of which deaths are due to COVID-19. In terms of the community surveillance, rapid mortality surveillance in Colombia, we are supporting government to expand the scale and scope of the Colombia Rural Vital Program to allow members of the community, key members of the community, key informants from the community, to report on the occurrence of death, and then enable municipal health officers to follow up on those reports, to confirm and to report on all confirmed death, and to trigger verbal autopsy where it is applicable. As a second example from Latin America, just a few words about the support that we are providing in Peru, where we are working to support the government to enable municipal health officers to work with the SINADAS system, which is a digital death certification and death registration system that is already in place, to ensure that every death is counted and to also enable the investigation of any death that may be due to COVID-19. In terms of the African examples that I would like to highlight, first on Senegal, where we are working with the Ministry of Health to support facility-based rapid mortality surveillance, specifically to enable medical record staff to transmit data on deaths that occur in 40 hospitals. These are the 40 key hospitals or 40 major hospitals in Senegal, to establish a system where there can be very rapid reporting of deaths that occur at these facilities to a central level to assess all-cause mortality. This will be using DHS2 for reporting, as this is a reporting system that's already in place. And then as a last example, this support with regards to rapid mortality surveillance in Rwanda, where we are supporting government to establish this such a rapid mortality surveillance system, both for facility and community-based reporting. At the facilities, we will be working with facilities that we have previously also supported to strengthen the capacity on medical certification of cause of death. The system will be ensuring that all deaths are captured rapidly and again transmitted through DHS2, which is the system that's already in place. And for the community-based reporting on all-cause mortality, we will be supporting the government to integrate mortality surveillance into the IDSR, that is the Integrated Disease Surveillance and Response System, which is already in place in Rwanda. With that, I hope we have been able to give you an impression of a bit more technical details of the system and mention a few examples. And I would like to hand it back to Philip, who will be discussing two technical issues in a bit more detail and talking about next steps and then wrapping up the webinar. Thank you very much.
Thanks, Martin. As Martin said, to round things out, I want to come back to just a few topics related to technical matters concerning rapid mortality surveillance, talk about data analysis and use, and then talk about next steps. Next slide, please. Thank you. The first, you've heard a little bit about historical levels of mortality as needing to be available in order to serve as a comparator for the currently observed levels of mortality. In the context of facility-based surveillance, we think these can be derived on the facility-by-facility basis from the last 3 to 5 years of mortality data where those data are available. In the context of community-based surveillance, it's important where possible to make sure that surveillance site boundaries are as contiguous as possible with administrative boundaries. In the technical package that I will talk about in a little bit more detail in a moment, that we are developing, as Martin said, in close coordination and collaboration with World Health Organization, CDC, and other stakeholders. In that technical package, we do list a methodology for estimation, but it's a challenging area and needs further thought, particularly where we're faced with the classic catchment area type of problem, where a surveillance site and its boundaries may cross-cut other administrative boundaries of 1 or 2 other units, and that makes it challenging to do measurement at that level. However, we do want to say that if no historical baseline is available, there's still the opportunity to begin rapid mortality surveillance measurement, get measurement to stabilize a little bit, and then use that as the baseline from which to observe trends over time. Next slide, please. As I mentioned earlier, we're aware of a high level of interest in the cause of death and in verbal autopsy certification and coding in the context of the epidemic. So that is going to be a subject of its own webinar in our series, and I won't get into great detail about the matter here. Obviously, it's something that deserves a great deal of thought. And in the context of rapid mortality surveillance, we have come up with 3 levels of investigation where feasible of cause of death in relation to total mortality. The first is to try simply to establish the manner of death, whether the cause was due to natural or unnatural causes, and then whether there is a way to easily discern a suspected pneumonia or acute respiratory distress syndrome case. And this methodology we can discuss further in the discussion time. The second is to focus on medically certified causes of death at the facility level, ensuring that this new ICD set of guidance and codes is implemented correctly, and that there is a good deal of rigor with regard to identifying COVID-19 mortality. And the third is to further investigate suspected cases, which could include medical record review and verbal autopsy in a facility setting, or triggering just a verbal autopsy, as we heard about in Colombia, in the context of community-based surveillance. Next slide, please. Sorry, next slide. Yeah, thank you. So to wrap things up, I have 2 more topics plus a summary to get through before we can get to some of your questions. And keeping an eye on the clock, I think we want to move swiftly to that part of the webinar. So let's go straight to the next topic, please. Again, in terms of data analysis and use, you've heard throughout the presentation how we're talking about excess mortality, which is basically to answer the question, how do observed deaths exceed what we expect to see? This excess mortality measurement and its use in conjunction with thresholds, we believe, can be an input into whether to loosen or tighten public health social measures, and can potentially serve as an early warning system to guide response and targeting of resources. Even though mortality is a lagging indicator, we acknowledge that, it can be useful in contexts where there is a challenge of getting a clear picture from a facility-based system where there's a need to include a community-based perspective or another perspective on where mortality burdens are headed in the context of the epidemic. Next slide, please. So to sum up, we've talked about how all-cause mortality surveillance, total rapid mortality surveillance, should be implemented as a core piece of epidemic intelligence required in this response, that it's the way to produce near real-time data for decision-making about the burden of the epidemic, should build on existing systems whenever and wherever possible, and use historical data for baseline wherever possible. We think that this approach will really capture the fullest picture of the epidemic burden and is preferable for reasons discussed during the webinar to case-based surveillance. Finally, we do want to emphasize that infection risks to surveillance staff really must be addressed. We can't really leave that issue anywhere in the parking lot because all of this depends upon a healthy workforce who are practicing safe behaviors in the context and self-protective behaviors in the context of the epidemic. Next slide, please. So what are our next steps? We have circulated a technical package, a draft for comment to key stakeholders for rapid review, revision, and we hope endorsement. Through the launching of that technical package, we want to deepen our partnerships with those partners and stakeholders to endorse these standards and begin to strengthen global and regional capacity to support the technical package. We can also envision on a regional basis setting up some kind of help desk type function or creating a moderated community of practice of countries who are trying to rapidly stand up rapid mortality surveillance. So with that, I'd like to move us forward in the webinar to the next section on questions and answers. we'll now look forward, I hope, to what we might do together in bringing more light and intelligence into the epidemic. And I look forward to answering some of your questions about that. For our Q&A, we're going to be joined by panelists, our colleagues from the Data for Health Initiative, including Emily Cerconi from the US CDC, Robert Jacob from WHO, Alan Lopez from the University of Melbourne, and Lynn Sifaraza from the Global Health Advocacy Incubator. So I think that I'd like to get started here by asking Lynn, from Geneva, Switzerland, we have a question about how birth and death registration services might be being affected in the COVID-19 epidemic. Will they remain open during the crisis? And is there any global guidance about what should be done?
Thank you, Philip. Thanks for that question. Civil registration should be maintained during national emergencies. Civil registration is an essential function of government, and in line with the UN principles on civil registration, it should be continuous and permanent, universal and compulsory. So civil registration functions should be maintained as continuous during this pandemic. And data that's collected during this time will be really useful for government policy and response both during and after the pandemic. So it's important that these essential services stay open. How it's affected during the pandemic, some countries may need to modify their notification procedures during this time due to restrictions in movement and to protect civil registrars from being infected. The UN Legal Identity Agenda Task Force has excellent guidelines out on maintaining civil registration and vital statistics during the COVID-19 pandemic. And it talks about how some of these modifications might need to take place. For example, shifting notifications to online if it's not done that way already, maybe allowing it by phone or post or email, other modifications to protect your civil registrars and to allow continuation. So I encourage everybody to check out these guidelines. I think we may have a link to it after the webinar in a URL link. But again, they are the UN Legal Identity Agenda Task Force guidelines on maintaining civil registration and vital statistics. You can find those if you Google them.
Thank you, Lynn. Robert, a question for you from Rabat, from Morocco. What procedures need to be followed in the event of a death at home suspected to be COVID-19 for the certificate of death? Are there any recommendations for verbal autopsy in this epidemic situation?
Well, thank you for this question, or rather these two questions. So if you have a death at home that is suspected to be COVID, you fill in the death certificate according to our WHO guidance that we recently issued, where you put the sequence of events, where there is a respiratory infection that is creating more and more respiratory trouble and leading to death. And at the bottom line, you will put suspected COVID-19. That means then that the case will be coded to the emergency codes in COVID-19 in the selection of underlying cause of death. The other point related to verbal autopsy, this is a topic that is under discussion at the moment, where we will come up with solutions from a verbal autopsy perspective. Of course, persons that died of COVID will show up like severe pneumonia or severe respiratory infection. And I think whatever verbal autopsy instrument you use, it will be very helpful to take note of the context, to have some certainty when the data is examined, whether this would be a case that is also suspected to have been due to COVID, or whether it's most probably not COVID. Back to you. Thank you.
Thank you, Robert. Alan, we have a question for you from Bangkok. How do you see this crisis changing how we monitor mortality in the longer term?
Thanks, Philip. So there are two aspects of monitoring mortality. One is the fact of death, capturing that, and the other is correctly diagnosing the cause of death. So we've heard a lot today from our colleagues in Vital Strategies about a system for improving notification practices or at least the importance of notification practices for capturing all-cause mortality. I think there's a lot of merit in that, but I think what countries and WHO and other agencies will learn from this is that we are extremely poor at the moment in capturing deaths in communities in many countries of the world. The overall level of registration or notification of deaths worldwide is about 65%. That means we're missing 1 in 3. I think the COVID experience and what we've learned today from our colleagues to use all-cause mortality will only work if we rapidly ramp up our research into what works in terms of improving notification of deaths in the community. So that's not both only community deaths, but also in-facility deaths. We know from experience that up to 20 to 50% of people who die in hospitals, known to the Ministry of Health, do not get reported. And so there's a tremendous leakage in in-facility death registration and notification practices. Both of those need to be addressed if the methodology we heard today is going to work. The other point is improving cause of death, as Robert has just mentioned. There's cause of death certification in facility. I think what we'll learn from COVID-19 is that doctors are often incorrectly certifying causes of death, are often unaware of the correct cause of death certification rules and procedures. Those will change. I think we will see an interest in doctors being correctly taught how to do that properly for public health purposes. The same as Robert mentioned for verbal autopsy, we are a long way from knowing how the correct questions, what are the correct questions to ask in order to correctly capture COVID-19 in a cost-effective way in a verbal autopsy instrument. Thank you.
Thanks, Alan. Excuse me. Adam, I'd like to there's a technical question here, an informational question from somewhere. I don't know where the questioner is based, but how were probable deaths defined in New York's data? Adam, you may be on mute.
Yes, this was, as Robert was saying, the mention of COVID-19 on the death certificate was the basis for the probable death.
Thank you. And then lastly, for this set of questions, we're expecting some more shortly. Martin, can I ask you to talk about how long it would take to get this system in place?
Yeah, sure. Thanks, Philip, for that. I think it really depends on the systems that are already in place, right? I mean, if there are, for example, reporting systems which are already there, if there is a surveillance system, even syndromic surveillance system that is running, those could be built on. The other thing that we find is that, especially for facility reporting, of course, facilities keep track of deaths that occur. They may not be reporting that on a timely manner now before COVID, but so that information that is captured could be used to report rapidly. And similarly, it is also often the role of community health workers to track birth and death in their community for various purposes. This is also not commonly reported rapidly, but that option exists, and systems for that reporting can be put in place fairly quickly to really establish rapid total mortality surveillance. Thank you.
Yeah, and I think it's really been a matter of weeks that we've been able to establish government buy-in, design the systems with local adaptation, and we are hoping to have our timeline is to have total mortality data running from as many of our country projects as possible by mid-May. So hopefully that answers the question there. Here's a question. Martin, I believe this is also a good one for you. Are there mobile-based applications that can be used to collect information offline and ensure there's no contamination or no infection of field reporters during the field response session, ensuring their protection?
Yeah, so we have been looking into various options. I think that this question largely applies for community reporting, and obviously, as we pointed out in the webinar, and as is obvious, it is very important to protect frontline medical workers and ensure that they are not exposed to any risk. We also are getting reports that even within the communities and with even though community health workers are not moving around as much anymore, not going house to house for immunization services or things like that, they are still getting reports. So they're getting reports through the telephone and so on. So there's definitely then options to set up SMS systems or USSD-based systems to rapidly report the occurrence of these events, also without the requirement of an app or smartphone even. I think that technology is part of it. It's obviously also about having really the reporting system in place and having informants that are well connected to the community that even without going house to house and exposing themselves to any risk can learn about the occurrence of death.
Thanks, Martin. Emily, I'd like to invite you to share some of your reflections on next steps and the resonance of this model in the context that you're familiar with and your colleagues at CDC.
Sure. Thank you, Philip. I think this was a really great webinar. I know it's been a challenge for the world to adjust to this pandemic and to know how to respond. I think we're seeing in the US that, we've been behind the times. And that we probably should have had our eye on measuring deaths much earlier than expected. And so I think in other countries, it's definitely imperative that deaths are monitored. In addition to finding cases, I know there's a lot of work to be done in terms of finding cases, but monitoring deaths is also very important. I think, some people have raised the issue of non-COVID related deaths, and I think that that's another important issue to consider. We know that there will be indirect deaths due to this pandemic that are not due to the virus itself, but are perhaps due to, lacking access to healthcare, lacking food or other necessities. So I think it's very imperative to look at deaths from all causes. That's looking at the total death counts is important because this may manifest itself in a variety of ways. And I think just overall too, these issues like many others in public health are very context specific. So it is hard to generalize these concepts in global guidance, but at a country level, I think it's important to look at all of the resources that countries have available to leverage the existing systems and the resources they have and leverage those to, bring that data to the forefront as quickly as possible.
Thanks, Emily. We have a question that I will handle. Are these locations for rapid mortality surveillance chosen based on systems already in place by Vital Strategies? Is there a plan for extending the locations? So the country selection was indeed based on existing relationships that the Bloomberg Philanthropies Data for Health initiative has had in those countries. Some of them are current, what we call focus countries in the Data for Health initiative, and others are countries that are part of the Data for Health initiative family and have been receiving grant support. So those countries indeed have been under the D4H, as we call it, the Data for Health umbrella. The plan for extending locations is really based on disseminating the technical package. As we bring together the coalition of stakeholders and global partners to rapidly rally around and solidify and stabilize the model that we're proposing. What we envision is making those resources, the technical package document plus any additional resources that are appropriate to provide, make that package of resources available to the world. And as I mentioned in the next step session, perhaps provide some help desk function or some sort of community of practice a type of environment where those who want to implement at their own country level can get some high-level technical backstopping and support. Robert, I have a question for you, coming back to you. There's a lot of interest in cause of death. I have a question from Turkey here that reads, in cases that are clinically similar to COVID-19, but more than one PCR test is negative, what should we code these as causes of death? Then the questioner says that according to World Health Organization, the patient presents with acute respiratory illness, testing is negative and COVID-19 is ruled out, but some doctors tend to code these anyway as suspected COVID-19 cases. Can you clarify this issue? Pretty technical question, but I know there's a lot of interest in disambiguating suspected from confirmed from other sort of respiratory conditions.
Well, that's actually what we also hear in the language that is used. We have people talking about COVID-related cases, about cases due to COVID, cases coinciding with COVID. So there is a whole range of clarifications necessary. And that's why we had the definition of the deaths due to COVID. And also being a clinician myself, sometimes there is uncertainty about the disease, and then you have to decide on your clinical knowledge whether you say it is a disease or not. Of course, if you have a good, reliable test according to WHO recommendations, and the test has clearly excluded repeatedly that there is the virus present despite the serious course of the disease, it would be clinically rather unlikely that this is due to the COVID virus.
All right, and Robert, I'm going to put you on the spot for one last question before I throw things back over to Carlos to wrap us up. Isn't it possible perhaps to look at somehow influenza deaths, pneumonia deaths, and COVID deaths together to get a sense of the overall COVID mortality? I'm not sure where that question came from, but that is a question about somehow lumping causes together to get an overall picture of COVID, the COVID burden of mortality. What do you say about that?
I would say that we have to learn more of what people die in the context of COVID. As you may have seen, there are recent publications that suggest that even myocardial infarctions could be there. There is a lot of research going on at the moment. And from a clinical point of view, of course, all three diseases may present so similar that without the virus testing, it is not easy to separate the cases. And to note that, let's say, 10% of the cases that usually die of something like that are stated to die to influenza are tested for influenza virus, and the others aren't. And we will have probably similar things with the COVID, where we say not everybody will always be tested. Nevertheless,
Right.
Clinical course, the context will suggest that it was rather COVID than an influenza.
Thank you.
As
Oh,
I
sorry.
said, we will learn more in the analytics in the future. Thank you.
Thank you. Sorry, Robert. At this point, we're coming close to the top of the hour, so I quickly want to throw back over to Carlos and just to express my thanks for all of your participation in this webinar, and we look forward to following up. Carlos, over to you.
Thank you, Philip, and thank you to all our presenters, and thank you to everyone across the world who has joined us today. Our next session will be at the same time, Wednesday, April 29th at 8:00 a.m. Eastern Standard Time. The CDC and WHO will present on certifying, coding, and using automated coding for COVID-19 deaths. Please note that this session has been recorded and we will circulate this recording to the group. When the session ends, you will be prompted to take a short survey, which should only take a few minutes to complete. Any questions we did not get to will be addressed in a subsequent email. Thank you again for your participation. We look forward to hosting many of you during the session next week. Please look out for an email with more information on that session. Thank you.